Dear friends, as we did for indentation, let's see what roles can be expected from vitrectomy. Here is what I presented in 2001 at the first EVRS Congress in Biarritz.
We can encounter numerous grounds for vitrectomy at each of the different operating stages. In brief, there are two main reasons to remove all or part of the vitreous. First, the vitreous causes discomfort. This can be optical discomfort, vitreous hemorrhage, very dense vitreous turbidity for the patient or for their examination and treatment of the retinal disease. Or there can be physical discomfort. The vitreous will complicate, prevent, or make dangerous intraocular work, such as the removal of IOL or dislocated lens, retinal dissection, retinotomy, retinopexy, etc. Or because we need operating space for a very important buckling, for a gas bubble, or for a PFCL or silicone oil injection. Second, the vitreous is or will be the cause of a vitreoretinal disaster. Due to a dangerous vitreous, infected or very pigmented, due to a vitreous traction, detachments by pure traction, or detachments where the tractional action is predominant, or due to vitreoretinal proliferation. Severe, beginning, or impending.
In fact, this was a very synthetic presentation of what vitrectomy can provide, but in practice, things look different, and we can distinguish two types of indication for vitrectomy. First of all, what I called in 2001 the indications that are independent of the PVR stage, which are in fact more exactly the indications that do not depend on the vitreoretinal clinical details that we talk about at the beginning of this playlist, and which are therefore closer to the ethiopathogenic circumstances of the detachment onset. These circumstances are so varied and difficult to classify that the EVRS-RD study could not study them.
Whatever the stage of the PVR, we can carry out a vitrectomy in different circumstances. First, RD with optical opacities. We can perform a vitrectomy when a vitreous hemorrhage is present. The hemorrhage can be severe, preventing RD diagnosis, which can be carried out by ultrasonography, or it can be less dense, allowing RD diagnosis, but without complete certitude of all tear identification. In these cases, I would be strongly inclined to carry out a vitrectomy. Here is an example where the entire temporal side of the retina was very visible with a tear at 11 o'clock. The vitrectomy allowed me to discover a small nasal RD with another tear. Without a vitrectomy, the spontaneous evolution of this RD, considering the growth factors provided by the blood, would have been very severe. With inflammatory or infectious turbidities, the vitrectomy is, in my opinion, much more urgent since the speed and severity of a probable massive retraction or giant tear is so great. The vitrectomy also serves to diagnose the infection and to inject an antibiotic. In this example, where the vitrectomy could have been completed even on the anterior side of the tear, a simple retinopexy gas solved the problem. Capsular opacity can also indicate the need for a vitrectomy. In this case, where a peripheral RD was diagnosed by ultrasonography, an additional YAG laser treatment could have caused an inflammatory risk by cellular expulsion in the vitreous. An anterior cleaning procedure could have been difficult due to a small capsular hexus. Performing a vitrectomy allowed me to analyze the detachment and to treat the tear. When an RD is combined with a lens dislocation, we must perform a complete pars plana vitrectomy. The same holds true for IOL dislocation. One hesitates to use liquid perfluorocarbon when its stimulating effects on cell growth are known. It seems better to pick up the IOL with forceps by selecting the more distant haptic. By this method, we benefit from the elasticity of the other haptic when placing it in the anterior chamber, before placing the complete IOL. An RD can be associated with other pathologies that require a vitrectomy by themselves, such as epiretinal membrane, macular hole, or ARMD. We must decide to treat both pathologies at the same time, or treat the detachment in a classical manner, with a 1-month follow-up vitrectomy for the additional pathology. All depends on the urgency of the associated pathology. Vitrectomy indication is virtually constant for an RD caused by perforating injury. In these cases, we must remove the posterior hyaloid for a faster and easier vitrectomy, but most of all, for providing a preventive measure by removing the collagen skeleton necessary to the organization and development of PVR and/or fibrovascular proliferation. For the same reasons, one can also remove the anterior hyaloid, and the peripheral vitreous. As well as any foreign body that remained in the eye. We can relate these traumatic perforating RDs to iatrogenous perforating RDs. First, perforation during local anesthesia. We can see all features from a simple RD with posterior tear, managed by retinopexy gas, to very severe PVRs with fibrovascular proliferation, where a vitrectomy would be indispensable. Second, RD with retinal incarceration after a perforating suture or subretinal fluid release. At least with tractional RDs, one is able to distinguish between 3 types. First, there is RD caused by a vitreous incarceration after a complicated cataract extraction. The sectioning and removal of the vitreous traction during the complete vitrectomy will transform this tractional detachment into a simple detachment without traction. The therapeutic alternative is a simple buckling, releasing the vitreous traction. The choice will be made according to the traction's importance. Second, there is RD caused by vitreous incarceration in a previous sclerotomy. We can either carry out an anterior buckling plus fold if the loop is small, or carry out a vitrectomy in order to treat the problem in a more radical manner. Third and finally, we have RD complicating a proliferating retinopathy. The causes may be diabetes, as in this example, or one of the following: post-venous thrombosis, post-Eales disease, post-angiomatosis, sickle cell disease, or von Hippel-Lindau, as in this case.
We could add an indication independent of vitreoretinal clinical details that the EVRS RD study reminded us of: the existence of great hypotonia or choroidal detachment. I have shown you in the previous chapters, thanks to the laser cell flare meter, that hypotonia is accompanied by a blood-aqueous barrier breakdown that acts as a vicious circle that must be stopped absolutely, and it is probable that changing the content of the eye, too rich in protein and inflammatory cells, can be beneficial for the evolution of the detachment. Let's now look at the indications for vitrectomy according to the clinical details of the detachment, and of course, in the absence of all the independent circumstances that we have just seen. And to begin with, is making a diagnosis of rhegmatogenous detachment an indication for vitrectomy? It might be tempting to think so, because in some departments vitrectomy has become systematic regardless of the type of detachment. Maybe that's why they don't teach the clinical finding of detachment anymore, since they do a vitrectomy anyway. Well, no. And the EVRS-RD study confirms it indisputably. A retinal detachment, whether retinogenic or vitreogenic, is not in itself an indication for vitrectomy. Retinogenic retinal detachment due to peripheral dehiscences, whether it be equatorial hole or dialysis, when the vitreous is not detached, or even contraindication to vitrectomy. This is demonstrated that the EVRS-RD study, as well as in my personal statistic, where out of 562 consecutive stage 0 retinogenic detachment, I have only performed 3 vitrectomies. One for vitreous hemorrhage in traumatic dialysis, one for detachment diagnosed by ultrasound because it was presenting a PCO preventing any peripheral examination, and one because during a drainage for dialysis, the vitreous has become trapped through the dialysis in the puncture port, preventing proper retinal reapplication. Of all these cases, there was only one failure. And again, for refusal of reoperation on a very old detachment, the patient didn't want to be bothered and said no more. Imagine how many failures I would have had if I had done a systematic vitrectomy. because the only way to obtain a failure is to perform a vitrectomy. Otherwise, there is no failures. And it's normal not to perform a vitrectomy because the vitreous has nothing to do with the disease. For example, in an equatorial hole, as we saw in chapter 9 of the playlist on the macula, the hole is probably due to a choroidal ischemia at the level of equatorial choroidal watershed zone. And there is a detachment only because the hole is related to an equatorial vitreous cistern, but the vitreous is not detached. If I insist so much on the need to identify these retinogenic detachments that represent 20% of the total of detachment, it is because performing a vitrectomy in these cases has serious consequences, because detaching an attached vitreous is not always easy. Here are two cases of pseudoschisic retinogenic detachment in two young patients, operated on by two very well renowned colleagues, excellent surgeons, but denying the existence of these stage 0, who fought for more than 1 hour to remove an adherent posterior haloid before finishing by retinotomy under drainage and silicone oil injection. When we see this, we can be revolted, because these are detachments that would have healed by cryo-drainage case or cryo-indentation drainage gas without any problem. No, really, stage 0 retinogenic detachment are contraindication to vitrectomy. The two exceptions to this statement are, first, when the retinogenic detachment is no longer stage 0. In fact, it is not because the detachment occurs without vitreous action that the patient cannot one day make his PVD like everyone else, the pigment then passing through the dehiscence and having the same repercussion that in vitrogenic detachments. The second exception is macular hole detachment, because it is out of question to make a cryopexy of a hole, of a macular hole, and because the removal of posterior haloid and ileum are essential for healing and repairing the damages. But when the dehiscences are peripheral, these restrictions do not exist and a vitrectomy should not be performed. If we now study vitrogenic detachments, is the identification of vitreous traction an indication for vitrectomy? One would be tempted to think so, since the vitrectomy section of the vitreous traction will definitively treat this traction, while the indentation only relaxes it. Well, the statistic of the EVRS RD study proves the opposite. In the majority of cases when the tears are peripheral and of normal size, there is less failure if an indentation is made than if a vitrectomy is performed. And this confirms my 2003 statistics of more than 2,300 stage A detachment that I had only treated by vitrectomy in 9% of cases for an overall failure of 1.65%. So, well, this does not mean much because there were giant tears, vitreous hemorrhage, paravascular tears, and macular hole in the batch. But if we exclude these tears, giant or macular hole, to consider only peripheral tears outside the giants, we see that the cases treated by vitrectomy have twice as many failures. Then here again, it is debatable because the cases are treated by vitrectomy probably have more worrying clinical characteristics than the others. One can also consider that my indentation technique is more efficient than the classical technique and improve the indentation statistic, but still, how to explain that the removal of vitreous traction through a vitrectomy can be more harmful than a simple relaxation of this traction by external maneuvers? Another interesting thing in the EVRE statistic is that detachment treated with a vitrectomy machine equipped with a venturi pump have more failures than if they are treated with an aspiration flow control machine. This clearly demonstrates that the aspiration flow control has an influence on the anatomical results. Depending on the type of fluid control you have, you will have to opt for cutting and aspiration parameters that will ultimately not lead to the same result. An example of this can be seen in the EVRE study, where in some stages of PVR, peeling of posterior haloid reduces the risk of failure compared to shaving. Vitrectomy is therefore not a procedure that can be indicated independently of the equipment and technique. It will therefore be very difficult to talk about vitrectomy indications when these indications will depend on your equipment and your usual parameters. This is why I will talk about all these in the following chapters. That said, the existence of vitreous traction detachment is not in itself an indication for vitrectomy. Why not? What can cause a vitrectomy to result in more failures than a simple relaxation of traction by indication? Well, for two different reasons. The first is the complication. I will not talk about cataract, which is not blinding complication that can lead to failure. I will not talk about endophthalmitis, which is blinding but rare enough not to influence the statistics. I will also not talk about retinal injuries due to clumsiness, because a learning curve exists for all techniques, even if for indentation, clumsiness has less severe and less irreversible consequences than for vitrectomy. I will talk about vitreoretinal incarceration, which is much more frequent than it is described in the literature. We have even learned from endoscopists that any ocular perforation, even for the simple placement of a chandelier, is responsible for vitreal incarceration. When vitreous incarceration also involves the retina, it is a serious complication that must be recognized immediately in per-up in the form of a small radial retinal fold. It is then necessary to stop everything to treat this complication before things get worse, either by extricating the retina by exchange or perfluorocarbon injection techniques, or in case of failure by a retinectomy limited to incarceration. The second reason for this greater failure of vitrectomy over indentation is that it is not sufficient to remove the vitreous traction to stop the retraction process if it is engaged. An indentation releases the traction, but if done properly, it also releases the base of the vitreous, which becomes essential if there is a small circumferential retinal fold. The vitrectomy, if it is to have a comparator role, must be infinitely complete, because releasing the vitreous base by vitrectomy is not simply done. And let's not forget, as we saw in the chapter on the role of indentation, that an additional limited indentation will no longer have a base relaxation effect if a vitrectomy is performed. So we see this incredible challenge for the vitreous surgeon to remove all the vitreous and peripheral vitreous, including the posterior and anterior haloid. At the level of retroequatorial retina, the posterior haloid is often very adherent or even completely integrated into the inner layers of the retina, to the point that the removal of the haloid, which is called as peeling, can be excessively difficult and dangerous. I myself have been confronted several times with the impossibility of performing a haloid peeling and have had to fall back by doing shaving, which has much less protective effect against post-op PVR. At the level of the pre-equatorial retina, the adhesions between the haloid and the retina, whether, as I have shown, in the context of an equatorial choroidal ischemia having led to astrocytic proliferation, or whether they are part of this physiological adhesion of the vitreous base, these adhesions therefore only wait for a small traction to cause a retinal tear. This is why Klaus Lucker revealed that in 10% of his complete vitrectomies, he detected one or more iatrogenic tears. The surgeon is therefore stuck in this infernal gamble of wanting to remove as much vitreous as possible by doing a peeling, but without causing traction, which is difficult to reconcile. This is why it often happens that he cannot go as far as he would have liked, even with a machine that controls the aspiration flow, for fear of doing damage. Because one thing is certain, as soon as you start having problems like iatrogenic tears, well, you enter in a process that you don't know very well how it will end. And then it is clear that the vitrectomy will carry with it either small iatrogenic tears or small therapeutic insufficiencies, responsible for a percentage of complications that an external indentation will not carry. The surgeon must therefore be a little humble about his ability to perform vitrectomies without complications, and must consider on a case-by-case basis the respective risk that his procedures will have in order to be able to progressively adapt his indentation to the more or less complex therapeutic needs that will arise. Thus, as we have seen, for a retinogenic detachment which only requires a role of obturation of the dehiscence, there is no reason to run this risk of complication brought by the vitrectomy. For a detachment with a small traction tear, the role required is to seal the dehiscence and release the vitreous traction And here again, this role will be accomplished more simply by an indentation. This indentation will be the more recommended as the tear will be located at the vitreous base with static traction, because not only is vitrectomy at the level more difficult, but also because the indentation will then relax the vitreous base and have a preventing effect on recurrences. Same thing if there is a small circumferential retinal fold. In the case of multiple tears involving 2 or 3 quadrants, and therefore requiring a long indentation which may alter the vorticus circulation, the question of vitrectomy may arise, provided that it does not cause too many complications. And this is where the choice of a machine comes into play, as the IVRS study shows us. The complication rate for machine equipped with an aspiration flow control will be acceptable, but the machine equipped with a venturi pump their complication rate will not be acceptable. The surgeon having to switch, therefore, to an indentation. The same is true for many special circumstances that we will discuss in my personal strategy, such as the presence of a large scleromalacia that prohibits an indentation, or an insufficiently bullous detachment to be able to perform an indentation plus a gas injection. So we will see that. On the other hand, if there is an intravitreous pigmentary turbidity, staged tears on several levels of or posterior tears well behind the base of the vitreous, the indentation will not be able to treat this element effectively and will leave its place to the vitrectomy, which will then become justified. The same is true in cases of giant tears or posterior tears. Several therapeutic roles are required in those cases: stopping the blood aqueous barrier breakdown, peeling the hyoid posterior, repositioning a retinal inversion, or cutting an adhesion on the posterior pole, a whole bunch of things that an indentation cannot do, and despite its inherent complication rate, vitrectomy is mandatory. The same is true, of course, for all the more advanced stages of retraction as specified in the IVRS RD study. However, I will make 2 small exceptions. The IVRS RD study advises us to perform a vitrectomy in all cases of stage B. This is understandable because the adherent hyoid plaque located just behind the tear, whose edge it fixes, can, if a classic and round indentation is performed, create forces that may cause the tear to redetach. But if you use the technique I have proposed with a non-elastic attachment and points allowing a protruding indentation with step edges, you will then use the role of reversal of retraction forces, and you will be able to treat this stage B provided there are only 1 or 2 incremented tears. Similarly, second exception, there are some stage C1 where a single retraction node is quite close to the base of the vitreous and located at more than 20 degrees from a tear itself on the vitreous base. In these cases, instead of doing a vitrectomy dissection, the outcome of which is always a little uncertain, You can have the tear and the retraction knot carried by a single indentation fold without having to do a vitrectomy. The knot being far enough away from the tear will not lift the edge of the tear, and the fold factor of the indentation will treat the retinal shortening due to the retraction. If this does not work, you can always perform a vitrectomy dissection in a second step. So, here are the indications of contraindication of vitrectomy for me. You can see that my indentation technique, a little more sophisticated than the average, allows me to be a little more conservative. You can also see that at no time in the indications I have included the crystalline lens status. As the RD study reminds us, there is no difference between phakic and pseudophakic detachment. At most, when the detachment has clinical characteristics that make one hesitate in the accuracy of a vitrectomy indication, for example, two retrobasal tears with a good pigmentary tendel in a 40-year-old subject, one will have less scruples about proposing a vitrectomy if the patient is pseudophakic. But that's all. In the following chapters, we will discuss the choice of surgical equipment.